This slideshow is one that was presented recently at the European Symposium of Suicide and Suicidal Behaviour in Tel Aviv by myself, John McGowan, of Canterbury Christchurch University, the clinical psychology training scheme here, and Dr. Lucy Hickey, a clinical psychologist in Oxley's Foundation Trust in Kent, a large mental health trust. And really, it's about looking at large-scale epidemiological research on suicide prediction, prediction of self-harm, and trying to really link from that to the decisions that are faced by clinicians working in mental health in their everyday practice. Okay, it's just worth saying at the beginning a few things about the origins of this paper. It really flowed from the supervision of newly qualified clinical psychology staff, and also other staff actually, sort of younger, less experienced nurses and social workers, and people in that kind of category dealing with suicidal risks, and also helping clinical psychology trainees think through this area. Both of us had been involved in the teaching and training of clinical psychology trainees over a number of years. A third area I think it's worth just pointing out and owning up to really is that it's also partly inspired, certainly for me, by my own experience as both a trainee and a relatively newly qualified clinical psychologist of being really quite confused to know what I should do when people were presenting to me with risks of suicide and self-harm. Okay, so the background really was very much about epidemiological research, and that was one of the areas which was both helpful and confusing. Now, epidemiological research may provide all sorts of interesting information, particularly about who is at risk and what kind of factors predict the risk of either killing yourself, trying to kill yourself, or self-harm where you don't know what the intention is, whether to kill yourself or just to hurt yourself, or it's a complicated issue. And there are many, many factors that can be involved when you look retrospectively at suicides: age, gender, poverty, nationality, diagnosis, diagnostic markers, particular sorts of psychological markers. One of the things that struck me when I went to this recent conference was that people were looking for biological markers. And also the influences that these have many uses, I think, and they can be very helpful, especially in influencing social and institutional policies. What should we do as a society if we find that, for example, young men seem to be at risk of killing themselves, or young unemployed men, or older people, or people who are physically ill. So there's something about targeting particular groups and developing response protocols, and I think this kind of research can be very, very useful for that. However, what about for clinicians? And this was really the sort of guts of the presentation. What about for clinicians? Because what do you know what how do you know what you should do when someone presents to you with a suicidal risk? And that can be very confusing, and I think this is where things got very confused. You're thinking, well, what's going to happen? How do I know what's going to happen? And trying to base your decision on that. And it should be said that no matter how good epidemiological research is, you don't have a crystal ball. You don't always know what's going to happen, and what you should do may actually be a sort of slightly separate decision from that. I think is one of the things I'm going to be arguing in this paper. Okay, so you don't have a crystal ball, and I think it's very, very important to remember that. Otherwise, I think there's tremendous pressure on clinicians, feeling that they should be expected to know what's going to happen with someone who's at risk. So no crystal ball. However, I would go even further than that and say, even if you did have a crystal ball, even if research on suicide prediction was so comprehensive that you could say what was going to happen in all circumstances, that would still only help you to a limited degree. If I was a philosopher, I would say something about kind of overlapping magisteria of knowledge or something like that. But I would go as far as to say that I'm not sure that that kind of predictive data is necessarily the domain of information that necessarily is apposite to the decision that you're going to take. So when do you try and prevent a suicide at all costs? I mean, that may seem, that may seem a strange question to ask, but do you always want to take all steps to prevent someone? Or do you want to try and help the person deal with their issues themselves, or stimulate some of their own resources? When do you leave something as their decision? Is it sometimes someone's right to do that? That's a big thing to decide. So there's something about what kind of help is appropriate, and sometimes predictive data I don't think necessarily impacts on that in a way that we might often assume that it does. Okay, so predictive data does not obviously pertain to the domains of these kind of decisions. Now, in these kind of decisions, I think one of the conclusions that we had in the presentation was we can't tell you what to do. We can't tell you. I don't think anyone can really tell you what to do when someone's when someone's presenting with a risk to themselves. But what we're delineating are three areas that may well be helpful. And those three areas are something about what's going on, the assessment of risk, trying to think about its meaning, understanding what you found in that assessment, and a question that I'm going to term what do you care about, the context and values and restrictions within which you're working. And the contention of this paper was that understanding things more fully in all of those domains may really, really help in terms of coming to a decision. Okay, so the first issue, what's going on? Now, I think we're just referring to the kind of assessments that clinicians often do. Certainly, it's bread and butter stuff for psychologists and other mental health professionals. Circumstances, background, medical history, social history, looking at if somebody has plans, but also formal ratings, formal questionnaires, which can seem to have some value in telling you about someone's state, and they're very useful because they help you to cover areas that you may not necessarily always cover yourself. And one area where I think epidemiological research is helpful here is it should tell you important places to look. It should tell you what are the domains that you should be looking at. Things like employment, isolation, things like that. And these things should ideally always be reflected in formal risk assessment documentation provided by organisations. So mental health trusts in the UK should be providing you with that kind of information, telling you where to look. Okay, but then what? And this is where I think the confusion sometimes comes in. You've got this information there, you've worked out that someone is unemployed, isolated, they seem at very high risk. How do you know what they're going to do? Well, the answer is you don't. You don't ever really know for sure what someone's going to do. So I think you have to start looking in a slightly different direction to help you make your decision. Okay, and the second area, and I think this is again something that for psychologists may feel like quite a natural part of their thinking, is trying to think about what the information that you found means, making sense of information that can seem desperately confusing at times. And in terms of that, I think that one really, really important area to think about is motivational state. How we make sense of the desire to hurt oneself or to die. And sometimes it seems to us that we can get caught in some quite concrete questions in services. Things like, does this person really want to die, or don't they want to die? That's a very kind of concrete, rather simplistic sort of duality. Another question I think both of us often heard asked in questions, or is this a cry for help? Do they want to die, or is it a cry for help? These may be, quite a limited way to look at things, and motivations may be far, far more complex and varied. So what would be more useful? And I think another kind of research can help here, and it's research into motivations. And certainly there are, large-scale studies, survey-based methods that, really suggest that there are many, many functions and motives of certainly of self-harm, which the picture on this slide is supposed to represent. So if you think of self-harm particularly, that things can be about, seeking care from others, expressing anger, stimulating some kind of emotion when people may feel very cut off, punishing yourself, or just simply a seeking of relief. There can be all sorts of reasonings behind suicidal or behind self-harm specifically. Another area that we have been I think particularly influenced by is work considering suicidal fantasies, particularly some discussion by Campbell and Hale in 1991. Um, Really outlining a range of suicidal fantasies. The wish for death, that can be about all sorts of things: revenge, anger, desire for atonement, a desire for kind of merger with, perhaps people who have died, or, maybe sort of a deity-like figure, or transcending the pain, the pain of ordinary life. And certainly, speaking for myself, these all things that seem to have come up within clinical work over the years. Also, the wish to take risks, which can sometimes blur into the we can sometimes perhaps confuse with the wish for death. So something about rescue, wishing to be rescued, or taking a gamble. Certainly, that wish to be rescued was something that came up very, very early for me in my own clinical career. Somebody who made quite spectacular, apparently suicidal attempts, but they seemed to be tied up to the wish to just step out of responsibility for complicated situations and have everyone just gather round and rescue the person. And that was a very thought-provoking scenario. Um, it is worth saying as a caveat to this that it's not always easy to know what people feel in terms of motivations. Research of the kind that I was talking about, sort of survey motivational research, that can help, but it's difficult. It seems an incredibly obvious thing to say. It's difficult. Why? Because these are tough issues, and it can be hard to talk. Self-awareness may be limited. When you sit down with someone, yes, I wanted to kill myself, I wanted to die. It might look as if somebody's had a number of attempts, for example, but they've been found on every occasion, or seem perhaps to have orchestrated being found. And that may also lead, I think, quite legitimately to some other questions about, what other motives may be at play there. Feelings may be ambivalent, actually. There may be more than one feeling at play, or very, very complicated. And I think that from our point of view, sometimes it seems that behaviour can sometimes be more revealing in terms of behavioural psychology, really thinking about the antecedents and the consequences of behaviour, and that perhaps telling you a little bit more about what may be going on, even in terms of what people can't necessarily always articulate easily. Okay, and I think that takes us on to the slide that I've slightly skipped onto, which is the third domain. So you've got some notion of the assessment, the history of the person, and some picture of their motivations, which, as I say, are not always easy. I think a third domain that can be really, really helpful and beneficial to think about are the kind of values and the contexts within which you're working, and to really ask yourself, what's important at this point. What are your own guiding principles? Is it to save someone's life at all costs? That may take you down a particular pathway of, perhaps hospitalisation, perhaps removing, the means towards harm, all of which may be legitimate if that's your aim. Is it something about trying to stimulate the person's own resources? Now that might involve, perhaps asking them to manage the risk, or you yourself or your care team living with the risk a little bit more, and maybe making an act of trust in the person to perhaps manage that a little bit more. Is it about minimising the risks a little bit back towards saving life at all costs, perhaps? Or is there something about perhaps respecting the person's rights, the person's right to take their own life in certain circumstances. I'm certainly not for 1 second advocating that if someone walks through the door and says, I want to kill myself, you're a mental health professional, that you just turn around and say, all right, that's fine. But I think that it is one potential thing that certainly a number of colleagues in mental health have said to me over the years, that there are times when they want to respect a person's rights. And perhaps something that's very important to realise, I think, about those guiding principles, or the kinds of questions that I've been asking, is that they don't exist in isolation. They don't seem to us to exist in isolation. There are a number of other issues, I think, which impact on them, a number of other contexts. I mean, of course, there are issues of personal ethics, but also something about the micro context of your colleagues, perhaps a team that you're working in. What are the aims, the ethos of that team? Is it something like a therapeutic community where you might be more geared up to, take a few risks around people, trying to stimulate the person's own resources, or is it something else where the aims of the team and the service are different? uh, Organizations, this can be very difficult, I think, for organizations, because some organizations certainly, in my experience, really, really try to support teams to, take what they might term positive risks at times with people, where they are thinking about, again, how to stimulate the person's own resources. But it can be difficult if someone harms themselves or kills themselves. That puts the organisation in quite a difficult position. So that I think can be very, very difficult. Is a very, very hard thing for people sometimes in senior positions in organisations to hold on to. The expectations within your profession, very important, just to not be flying by the seat of your pants. What is the professional guidance around these things, and how can you assimilate that into decision making? What are the pressures from, for example, families or systems around an individual where someone's at risk? That is going to impact on the kind of principles that are at operation. What's the national culture that you're working in? An American colleague of mine, when I first gave this talk, said, well, when I worked in the US a number of years ago, when someone was manifesting a suicidal risk, you sent them to hospital. What else would you do? There may be other ways of thinking about that, but it was very hard to do anything else but send someone to hospital in that circumstance. What are the legal factors at play? Also something that's very, very worth thinking about, especially if you're a mental health professional. You could be called to coroner's court and you have to justify your decision. So what's the legal framework that you're working in terms of how much can you say that somebody is capable of holding responsibility for themselves? And that may vary from national culture to national culture as well. All of these domains that we're talking about aren't necessarily perceived in our thinking anyway as a way to simply make a decision, or you get this information and the decision is automatically obvious, but they're really envisaged as a way of supporting the decision that you might make. Thinking about assessment information, thinking about really a deeper knowledge of the behaviour and the kind of motivational states that seem to underlie it. As we said, not always easy, but also thinking about the guiding values and principles, the context in which you may be working. And it seems to me that all of those things may be very helpful in supporting a final decision that you may make. The question arises on the back of that, of course, it's whose decision. We've talked a lot about clinical practitioners and what they can do and what they should be thinking about, but it's not just your decision, it's also the decision of the person as well. How do you get the person involved? And I think hopefully this reasoning process may, certainly when you're particularly thinking of the values and context element of it, may highlight the need for the person actually to be involved in that process. And trying not to make the clinician the solution always. If clinicians are always the solution, or if suicide is simply seen as an illness to which the clinician is potentially the cure, it's a very, very difficult situation. You're asking clinicians ultimately to take responsibility for people's life and death, and that seems to me to be an untenable situation. So really thinking about how do you involve the person at every stage. And to finish off, I think it's just worth reiterating, you can't always know. You can't always know what's going to happen, and one can put oneself under a huge amount of pressure as a clinician to know and to feel that you should have the answers or that you should be able to predict what's going to happen. What you can do as a clinician, I think, is that you can remain curious about what's going on, and for each individual there's something to be understood. It seems incredibly obvious to say, but everyone is individual, everyone is unique. There may be similarities, but there seems something hugely important about trying to understand each individual's trajectory through this really very painful issue. What we've tried to offer in this presentation is a framework. But perhaps it's also important just to think not to let that framework tie you down. What we've tried to offer is areas, domains where you can think, but not be tied down by what you come up with. And hopefully that may be helpful to some of you who've got this far. If it's not helpful to you, I think that's fine. But it seems to us that this kind of decision framework or something like it may actually be quite a helpful way of moving forward when you're faced with these very difficult situations and risks.